Hello, welcome to AMCI Saturday Study Session, or SSS. I'm Mrs. J, Curriculum Director here at AMCI, and I am delighted to present AMCI Lead Instructor Ms. Tamika along with her guest. Without further ado, let's get started. Take it away, Ms. Tamika.
Morning. Hey, I see you guys in there. Hey, Miss Erica, Fatima, Giovanni, Regina, and Renita. How are you, ladies? I see Miss Dana in there. Good morning. All right, does everybody have their forensic glasses, their coffee or beverage of choice? I mean, we got to get ready. We got to get ready. And look, you guys know I got to bring my pup along. Yeah, I agree. What do you guys think? I think that coffee, it just doesn't taste right when they spell your name wrong. It just gets to you, like, man, I need y'all to get it right, okay? So I know you guys are ready. I know you got your books, your favorite pen, all that good stuff. So we go over our copyright, CPT copyright 2020, American Medical Association, all rights reserved. CPC is a registered trademark of the AAPC. AAPC content found within this presentation is copyright of AAPC. Keyword concept, FTR, Chun, AMCI Fab 7, AMCI, ICD-10, Flip, Tap, R, trademarks of AMCI. All right, are we ready? Are we ready? We're almost there. Hey guys, do not forget that feedback or that survey after class this morning. We want your feedback. You guys know why it's important. It helps AMCI deliver quality classes to you wonderful folks. It helps your instructor help you. It helps me, Ms. Tamika, do what I need to do to assist you on your coding journey. No feedback means no good. Please talk to me. Talk to me. Let me know how your experience is today. All right. It is important to us. You guys are important to us as we are AMCI family. All right. Miss Chinway is gonna hop to it. Look at there. We only 3-4 minutes in. I mean to get a lot of these things in. Let's get ready to code. All right, Miss Chinway, here we go.
All right. So we're starting with the answers. A, 61850. Oops. B, 61863. C, 61867. And D, 61870. A 55-year-old man presents with uncontrolled tremors that have become quite severe and are not disabling. A trial of a deep brain stimulator electrode is recommended. The patient is placed in the head holder adapter for the frame. The scalp is incised, exposing the skull using a perforator to make a single burr hole 2.5 cm from the midline at the level of the coronal suture, exposing the dura, and is punctured for access. Microelectrode recording (MER) and stimulation is done to target and reposition the electrodes to determine the best placement for the neurostimulator electrode. The neurostimulator electrode array is placed in the thalamus and fastened into position with radiographic image monitoring placement. The lead is coiled in a pocket under the galea, which is suture closed, followed by skin closure. What CPT code is reported? And you have 2.5 minutes. Thank you.
All right, guys, I see everybody's getting their answers in here. All right, and we're going to take a look at it. And I know we have some B's and C's, and I took another look at that thing. And I'm like, hold on. I think I solved it and put the wrong one. So we're going to go through as to why it definitely is C and not B. Okay. All right. So we've got our keywords here. We've got uncontrolled tremors, scalp incised. We've got the single burr hole. We've got the microelectrode, the MER, and then we have the neurostimulator electrode array placed in the thalamus. Okay. And then we're going to take a look at these codes. We have code 61850, which indeed yes, it should be C. Okay, so I solved it for C and put B on my answer. Okay, so we're going to take a look at, for those of you that were going with B, and I think most people caught it, and I did too, because believe it or not, even when I make the slides, sometimes I'll put the wrong answer there and I solve it real quick before we do it. And I thought, uh-oh, I put the wrong one. So you guys already saw 61850. It is a burr hole. Okay. And we see there we have burr hole, and we're matching up these keywords, but it's in the cortical region, and we in fact are coding in the thalamus region. Okay. So we're going to take that one off. All right. So we're going to do away with 61850. We're going to move along here and take a look at code 61863. Here we go. We do have that burr hole. It's of the subcortical site, but it is in the thalamus. I like that, but it's without the use of the intraoperative microelectrode, and we in fact do have that microelectrode. Okay, so code 61863, yes, B is not the correct answer. So like I said, yeah, it is C. I caught it while you guys were timing, and I thought, oh. So yes, Miss Chinwei, I chatted her and said, no, it's C. Okay, so good eyes on that one, guys. And hey, like I said, I'm coding along with you. There we go. We've got that burr hole again. And then we have the subcortical site, thalamus. Yeah, that grabs it. And that's what we need right there. Yeah, we do use that intraoperative microelectrode. We have it right there. And thus, we're going to do our due diligence before we sign off on C and take a look at this 61870. Oh, no. We didn't have anything to do with that craniectomy. And we're not even in the right region, okay, even if it were. So the procedure is wrong as well as the area. So that clearly is not the right answer. And yes, the answer for 61867, it is C. Yes, those keywords. So yeah, I flipped it on that first one. I apologize, but I solved it here with C. So yes, it is indeed C. So I see some of you are like, ah. So yes, this was a matter of just matching up those keywords. So how we feeling, coders? Is this, you guys did great. Okay, I'm liking what I see. You guys are ready. We're gonna keep on moving. And I'm gonna read this one, and then Miss Chinwei will come after me. We're gonna go back and forth, but I'm mostly gonna have her read. But I'm gonna grab this one, and we're gonna start with our answers first. And we have A 62350, C 70.0. We have B 62362, C 70.1, C 62360, and C 70.0. D 62367 and C 70.1. A patient who has a malignant neoplasm of the spinal meninges is receiving a programmable pump implantation for chemotherapy. The patient is placed in the prone position where the provider made a midline incision overlying the area of overlying the area, I'm trying to get that little thing to go away, overlying the area of the spinal cord. The reservoir was placed in the subcutaneous tissues and attached to the previously placed catheter. Layered sutures were used to close the incision. The patient tolerated the procedure well and was released in good condition. What CPT and ICD 10 CM codes are reported for this position? All right, coders, we're going to do 2.5 minutes. Hopefully you didn't see that answer pop up there. Go ahead and solve this scenario. All right, coders, we are time's up. We even went, I let you go a little bit longer by several seconds so we could squeeze those answers in there. And I see lots of good stuff. I'm sorry about that, Miss Argentina. All right. So we're going to go on in here and trust me, I got lots more for you to do. All right. Here we go. We're going to take a peek as to why this answer is indeed B. And many of you guys already know that. But those of you that were off just a bit, we're going to take a peek as to why it wouldn't be C, and indeed it is B. So our key words is malignant neoplasm of the spinal meninges. We have a programmable pump implantation for chemotherapy. Prone position of the patient. The provider has made a midline incision along the area of the spinal cord. So we're going to go ahead and start. One thing I'd like to definitely remind you guys of, particularly when you get into longer chapters, is be aware of where you are in that chapter. Here, we're talking about catheter implantation as we go along with these series of codes. And indeed, we are looking for a implantable pump. Okay, so that lets you know right off, hey, anything falling in here, that probably would not be right. Okay, so we take a look at that first code here that we're looking at, 62350. It is an implantation, revision, or repositioning of a tunneled intracatheter or intrathecal or epidural catheter. All right, so we're not dealing with a catheter, we're indeed dealing with a pump. So 62350, yeah, that's no good. All right, so the next thing we're going to do, I'm going to take a look at the next codes. And yeah, right here we see we're in the reservoir pump implantation area of this code chapter. So yeah, we're in the right neighborhood now. Okay, so definitely don't forget these the different sub areas, the subsections of each of your code chapters. Okay, it'll help to guide you along, because I know if you're like me, you're thumbing along, you're trying to get there, but be aware of where you are in that book. Okay, and that's why Mrs. J advises you to put that up at the top and put your FTRs at the bottom so that you can quickly look up there and you can see, yeah, I'm in the right neighborhood. All right, so we're going to keep moving along. We're going to take a look at code 62360. It is indeed an implantation or replacement of a device, intrathecal or epidural, for intrathecal or epidural drug infusion. Okay, and it is of the subcutaneous reservoir. All right, so no. That's not what we need. We are looking for a pump implantation. Okay, this is talking about a subcutaneous reservoir. So this code, this common code language was looking all right, but yeah, that's good, but not the part that's specific for this code. So don't forget, when you get to a code family, as long as the common language is good, you're good. Okay, so don't forget that everything before that semicolon, that's common code language for everything that's indented. That's letting you know these are dependent on this common code language. So this part that goes after the semicolon, the subcutaneous reservoir, that's not good. It's specific for just that code, but that makes that code no good. Since this code language is good, let's take a look at what falls beneath it. Yeah, you know what? I like this dependent 62362. We've got that implantation. That's what we need. And it is of a programmable pump. Let's put a little star by that and hold that thought. Let's check out that last one to see if it's a player. Look at there. We aren't even talking about implanting a pump without talking about electronic analysis. Okay, so they're implanting something is programmable, but they're talking about electronic analysis of the programmable implanted pump. So yeah, that's no good. 62367. Okay, that's talking about something that's not mentioned. So yeah, if the doctor didn't say it, it didn't happen. Not in this case. So that code looks good, but let's check out that last one just for good measure. We have C70.1. That's malignant neoplasm of the spinal meninges. So yeah, C70.1 is good, so we're going to sign off on it. And please know, when you are on that exam, You do not have to go to that ICD-10 CM book, okay? Not when you're coding for different types of procedures, okay? Stay in that CPT book as much as you can, and for the most part, you'll be able to. All right. So until you're at the section that you're having to do some ICD-10 CM coding, stay in that CPT manual. Okay. So how is everybody doing? All right. The subcutaneous reservoir, don't get hung up on, okay, is this, what is it, what's that? You can always look it up if you want some more specifics, but don't get hung up on it, okay? What you want to know is, does it match it up, okay? So subcutaneous, you're going under the tissue when you are dealing with this particular device, okay? But you can always, look it up, Google it if you want to get some more stuff, okay? But I want to get you matching up the keywords and stuff, okay? So we won't get hung up on it. You're gonna know that it's up under the subcutaneous tissue, and that it is indeed an intrathecal device, okay? But what you want to do is be moving along real quick. It didn't say anything about that, so it's no good, okay? All right, so we're gonna keep on moving. If anybody needs to grab this screenshot, you can do it, and then we're gonna keep on trucking, because hey, I want you to get some good stuff and great questions as well, Miss Aisha. All right, let's do it. And hey, I already told you guys, pay attention to these headings and subheadings. It'll help to guide you as you make your code selection. All right, Miss Chinwe, I'm going to give you this one, lady. Let's do it.
Okay, and the answers are A, 63050, M, 50.21, B, 63020, M, 50.21, C, 63020, 63035, M, 50.91, and D, 63050, M, 50.91. A patient with a herniated cervical disc undergoes a cervical laminotomy with a partial fascectomy and excision of the herniated disc for cervical interspace C3 to C4. What CPT and ICD-10 CM codes are reported? And you have 2.5 minutes.
All right, I see lots of good stuff there in that chat. All right, so I think everybody's got their answers in. I'm giving everybody just a few moments, and then we are gonna start talking about how we got to the right answer, and most of you have figured it out. So let's go through it, all right? See if I can give you just a few quick tips, even though you've blown through it. All right. So our answer is indeed B. All right. I think I was on a roll with those B answers. So we're gonna take a look at it, okay? All right. Our keywords are herniated cervical disc. We're undergoing a cervical laminotomy, the partial facetectomy, and excision of the herniated disc. Okay, so we have a laminotomy and a facetectomy. All right, so we're going to go ahead and start with our first one. We're taking a look, like I said, pay attention to what we are doing. All right, we have a laminotomy. And for the first one, 63050, all right, that's talking about a laminoplasty, all right? So we didn't fix it, okay? We didn't repair it. We are making an incision into it, all right? So 63050, we're gonna take that one away. And we're gonna hop back up here to this one, all righty, with the 63020. Well, not quite. Here we go. We got this one here and here. All right. So I'm telling you guys to notice. I'm just jumping up there. I love when you can have a BOGO, meaning you can have buy one, get one. So, hey, just knocking that out straight away. Boom, we're already at 50/50. Okay, that's some good stuff when you can do it like that. Now we're gonna get up here to this 63020. Okay, I'm just eager to get there. Yeah, that's some good stuff right there. All right, it's got everything we're talking about. We've got that laminotomy. Be sure you pay attention if it's laminotomy or it's ectomy. Okay, we do indeed have that decompression. We have the partial facetectomy here. There we go. For the herniated disc, we've got the laminotomy, and then we've got the partial facetectomy. Okay, now we've got one inner space. Okay, the cervical inner space, and indeed, there we go, C3 through C4. So make sure you know your segment. So if you have C3 and C4, how many segments do you have? And remember, the segment, it is the bone itself. It's each of the bones. That's right. You have two segments. Okay. The segment is the vertebrae. Okay. So remember that. Make yourself a note. Remember, this thing is open book. Okay. And then how many intervertebral discs do you have? How many interspaces do you have? Okay, yeah, you've got one interspace, and it's the segment in between. Okay, and I kind of, the way I remembered, if it's C3 C4, it's different if you have a range, but these two are close together. So I just think of that little dash as the intervertebral disc, but this only works if you're not talking about a range of a vertebra. But if you're just talking about two, then that little dash could be like the inner space. Okay, yeah, that's your space. So we have one cervical inner space. So we're good there. All right, so that's why that works. Okay, and all of these different things happen. Now we've got to figure out the difference here on two fronts. This first code is the same, but here we've got this 63035, and it's telling us for, we hold that just like we said with this, it's for each additional interspace, cervical or lumbar. Well, do we have any additional interspaces? That's why I asked you that question. What's the difference between that segment and the interspace? Yeah, we don't have any additional ones. So don't get tripped up, because it'll trip you up if you start counting segments. Yeah, you would need one more because you got two, but we're talking about the interspace. Okay, hey, that's all right. This is the place to get that aha, like, oh man, that's my bad. Hey, have that moment right here. Okay, so that's why this one's no good. We don't need that. Okay, we have just one interspace, and so that's why B is it. We're just doing the due diligence, showing you what the M5020 is. It is for the C3, C4 cervical disc displacement, okay? So we're going to sign off on that one. B is it. And again, on that exam, don't you go looking this up. See, you already got the answer. I'm just showing you what it is. So if anybody's like, is that it? How do you? Okay, I'm just showing it just for clarity's sake and just to be thorough. But on that exam, don't you go looking this thing up unless you need to break a tie. Okay, if for some reason you have two answers and the only differentiating thing is that ICD-10 CM code, then you go and you break that tie. Other than that, stay in that CPT manual. Okay. All right. So how we doing? I think everybody's good. Everybody's sipping on your coffee or your water. All right, good. I got a couple of goods. All right, now it's not that many of you in there, so I ought to hear from everybody. Okay, I only Miss Renita, Fatima, Argentina, Dana, and Andrea. They're the only ones that are good. Water on deck. That's right, Andrea. All right, let's do it, guys. We're gonna go ahead and follow this next one. And again, noticing those keywords, because if you notice, we had 4 that matched. Okay, that's a good one. All right, I'm glad you're good too, Miss Aisha. Yes, Erica, you got to be truly forensic. Get your glasses on. I got mine hanging on my nose and a new pair on the way on Monday. All right, let's get this next one. All right, so we have A 60520, B 60521. C 60522, D 60540. The provider removes the thalamus gland in a 27-year-old female with myasthenia gravis. Using a transcervical approach, the blood supply to the thymus is divided and the thymus is dissected free from the pericardium and the thymus is removed. What CPT code is reported for this procedure? All right, here we go, coders. You got 2.5 minutes. You ladies, you all have got this. Let's go. Oh man. Look at y'all code when you're just showing out. When you're just showing out, because that's what y'all are doing. I mean, come on. This is amazing. I'm loving it, loving it, loving it. All right. So we're gonna hop to it. You guys already know what to do. I'll see if I can just give you just a few pointers, and we're just gonna just breeze through it because you guys already got it, okay? But I'm gonna do my due diligence and just go through it anyway, okay? You guys already know it's A. I'm giving you all an A on this because you guys are coding like a pro. I see you guys. You guys are just doing your thing this morning. All right, this provider is removing that thalamus gland of this 27-year-old. They have myasthenia gravis. They're going with a transcervical approach. The thymus is dissected. It is removed. All righty, so we're taking a look at these codes. Don't you love it when you notice these first three here? Let me bring your attention to that. You see that 605, 605, you know, hey, they must be close. They must be close. They might be in the same neighborhood. So indeed, they are very close. So we're looking at that 60520. It is a thymectomy. All right. Yeah, the thymus is removed. Transcervical approach. Yeah, that's removed like that too. We're going to hold that thought. All righty. And then we drop down here to this dependent code. All right. It's talking about a sternal split, a transthoracic approach. Nah, that's not it. So we took that one off. You guys already did. You all already picked up on that other dependent with the sternal split or transthoracic approach. Nope. That wasn't it either. You took that off, and then you took a look at 60540, adrenalectomy. They were just way in left field. Nah. So there we go. You guys got that one. And you will see some like this on the exam. And you don't want to leave these type of questions on that table. You want to get through it quickly, just as you did this morning, so you can move on to some others that might require just a little bit more of your attention. All right. So terrific job. I'm just gonna shout out all of you. I saw Miss Aisha in there, Andrea, Argentina, Cheryl, Andrea, Renita, Erica, Rosanna, Dana. I saw Dana with some great keywords. I saw lots of you with great keywords. Renita jotted some keywords down as well. I saw Giovanni in there. I saw Regina, Fatima. I saw Fatima again. I have two Fatimas, and I saw Rosanna. I saw Erica. You guys, hey, outstanding. All right, I'm going to have my buddy come on. Hey, you ready? Are you ready for a coding exercise? Somehow I feel like your brains are just like on fire. You're doing yes, y'all are on fire, Renee. Y'all are. All right, Miss Chinway, you have the floor, lady.
All right. A 61521, B 61524, C 61598, 6161651, and D 61597, 61616, 51. A 50-year-old male is diagnosed with a tumor of the skull base just below the occipital tonsils. The neurosurgeon performs a transpetrosal approach to the posterior cranial fossa. He then performs an intradural removal of a tumor of the posterior cranial fossa at the base of the skull. Dural repair is done and the area is closed with Neurolon. What CPT code are reported? Thank you.
All right, I see lots of answers coming in there. All right, like I said, somebody put them out. Somebody put them out. Y'all are on fire in there. I tell you what, again, no fooling you. No fooling you. Okay. So, did anybody notice something that could narrow it down right away? Now, I'm going to go through each one of them. But did anybody notice when you looked at these particular choices, and you guys like unanimously said C, but what jumped out at you when you were looking? Okay. Hey. Yeah, yep, A and B, it was a craniectomy. Yes, that's right, Tamika. Yeah, and that modifier. Now, when I was first learning code, I would shy away from that. I was still gonna go in order of those codes, okay? Nothing wrong with that. But when you take notice of when you get to that page that is talking about surgery of the skull base, take a look at those FTRs to see if some type of modifier comes to mind that could get rid of some things. And definitely your keywords, yes, always those keywords are key. Okay, let's pay attention here where we are. You guys already, like I said, you guys solved it simply outstanding. I'm just giving you different ways to look at it, but you guys, you knew what to do. Again, we have that tumor, it's at the skull base. We got that neurosurgeon, they're performing the transpetrosal approach to the posterior cranial fossa. Then he performs that intradural removal of that tumor at the posterior cranial fossa at the base of the skull. Okay, and then we have that dual repair that's done. Now, it's posterior, okay, approach. All right, I got my FTRs down here. Okay, so we got the transpetrosal approach. It's to the posterior cranial fossa. All right, and then intradural, intradural removal of that tumor. All right, and then we have here, we have intradural removal of the tumor, and then it's from the base of the posterior cranial fossa. All right, so we need that approach and the definitive procedure to match. Okay, that transpetrosal approach to the posterior cranial fossa, and then we have the posterior cranial fossa, which is the definitive procedure, which is the removal of the tumor. Okay, so the approach and the definitive procedure, that those things, we need those to match, particularly if this FTR applies. And in this case, it does. Now, what about that 51 modifier? Here I go again with these subtitles. There we go. But I figured out how to turn it off. All right. So that 51 modifier, yeah, we have the same provider doing the procedure. So you guys already know it's C, but let's go ahead and go through these things. Like some of you have already said, that A and B, yes, we're talking about a craniectomy, all right? And we don't need that, all right? So we go up here, we already know that if this parent is wrong, anything that falls beneath it is going to be wrong too. So immediately we can get rid of that 61521. All right. And then for the 61524, again, a craniectomy. And yeah, that's no good as well. So we're going to get rid of it. All right. So that brings us down. Let's take a look at where we are. Like I was saying, pay attention to those headings. We need that posterior cranial fossa, posterior cranial fossa. All right. I'm in the right neighborhood. Let's find that house. All right. So for 61597, transcondylar approach, what happened with this approach? You guys already picked it up. I'm not even going to wait for you in the chat because you already know. I'm not going to waste a second of your time. That 61597, that's got to go because we have a transpetrosal approach, not transcondylar. All right. So we pick it up with 61598. It is indeed transpetrosal approach to the posterior cranial fossa. Let's do our due diligence. Okay, we're paying attention to where we are. We got to find that base. It's telling us we're at the base of the posterior cranial fossa. Again, matching those keywords up, okay? Helping to guide us along. Don't be like some folks in the car. Every now and again, my husband will do it. He won't ask for directions. But pay attention to these headings, these subheadings as well. It will point you in the right direction, okay? So we have resection or excision, all right? But what we need is, this is extradural, but we have intradural. There we go. Intradural removal, still having to be forensic when we get in the right spot. But you guys, you pegged it. And here we go. If that one surgeon performs more than one procedure, and he did, it tells us he performed the transpetrosal approach, the neurosurgeon did, and he then performed the intradural removal. So that's telling us he did them both. Okay. And so that's why that 51 modifier would be needed. All right. So that's why that's the right answer. That's why I was asking you about that 51 modifier. Once you get comfortable with the modifier, then you came to your FTRs at that page, you'd start looking and you're like, okay, did he do both? You start reading. Yeah, he did that. He did that. Okay, yeah, I could get rid of those because number one, I don't have enough procedures. And number two, I'm gonna need that 51 modifier. So let me hone in on these first, okay? But you have to be comfortable to do it like that. But I'm just giving you a different way of looking at it. But you guys did outstanding. Wonderful keywords. You guys are doing amazing. If any of you need a screenshot of this, you can grab it and we'll move on. But you guys were just on it, okay? On it, on it, on it. I'm loving what I see. So we're going to keep on moving. All right. Are you ready? Look, we are working it out this morning. We are working our brains, okay? If you guys brains, now you might have flat abs, but I always say if my brain was reflective of what my abs look like, I think I might have a six pack. I think. I don't know. I don't and from what I'm seeing this morning, I think all of you would too. I think we all have flat abs. We got flat abs, Andrea. All of us do, okay? Because we working it out this morning. All right, so I'm gonna read this one, and we're gonna start with A 63087 with a 52 modifier, 63088 with a 52 modifier times 2. B 63085 with a 62 modifier, 63086 with a 62 modifier times 2, and C 63087 with an 80 modifier, 63088 with an 80 modifier times 2, and finally D 63085, 63086 with an 82 modifier times 2. All right. A 47-year-old female presents to the OR for a partial corpectomy to 3 thoracic vertebrae. One surgeon performs the transthoracic approach while another surgeon performs the 3 vertebral nerve root decompressions necessary. How should each provider involved code their portion of the surgery? All right. Okay, coders, you have 2.5 minutes and your time, it starts now. All right, coders, you know what that sound means. Hey, you guys, hey, on fire, on fire. Okay, okay, like I said, cha-ching. Show these coders the money. All right, yes. Renita's like, yes, show me the money and be sure you spell it right. It's RENA, not NITA. Okay. All right, guys. Here we go. Let's take a look at how we got there, okay? Most of you got it, and then some of you almost got it. You're right there, okay? And I'm gonna get you there to show you why you gotta like you were making that right, but I needed you to just kind of ease over into the right lane a little more, okay? All right, so here we go. Let's take a close look at this one. It is indeed B. All right. So here we go. All right, so we have our keywords: 47-year-old, partial corpectomy, 3 thoracic vertebrae, 1 surgeon performed the transthoracic approach, and the other performs a 3 vertebral nerve root decompression. Okay, and we need to code for each provider. All right, so B, so we have first thing we're going to take a look at: partial corpectomy. All right, 1 surgeon, and then the other surgeon is taking care of the 3 vertebral nerve root decompressions. All right, each provider. All right, so 63085. We have a 63087. Uh-oh, my on clicks are off. Okay, so we're going to start with that one. 63087 with a 52 and an 80 modifier. Okay, so let's take a look at that one. We're talking about a vertebral corpectomy. All right, partial or complete, but here's the thing that catches your eye: it's of the thoracolumbar approach. All right, we have a transthoracic approach. Okay, so we're going to take that one off. All right, I think many of you caught that. All right, so that's why that one's gone. All right, so now we're going to double back here to the 63085. That's what we have left. And like I said, I love it when you can get that BOGO, that buy one get one, but then in this case we find one and we get 2 for 1. Okay, we find that wrong code and we're able to eliminate 2 of them. Okay, so we head on up to the 63085. Now that is good for both of them, but one of them has that 62 modifier, one of them doesn't. So we have 1 surgeon. All right, and they're performing the vertebral corpectomy, which is what we have, and it is partial or complete, and we do have a partial, so that is it. And it is of the transthoracic approach. That's in the code language, and it also takes care of the decompression of the spinal cord and or nerve root or roots. Okay, and we have thoracic single segment. Okay, 1. All right, 1 surgeon. There we go. All right, now, but we have 3 vertebral vertebrae. So we have the 63086. Okay, so we have the thoracic, each additional segment. Okay, so with the each additional segment, how many do we need? Because we have 3. So the first code takes care of 1 segment. Okay, and so this add-on code, okay, each additional segment, so we need what modifier? This is telling us we need a multiplier. Okay, so with that multiplier we have the ×2, which I think many of you caught that. Okay, we've got the ×2. All right, so that's good because we have 3. So we have 1, and then the ×2 takes care of the 2, 3. Let me also bring to your attention, when you see each additional segment or each additional whatever comes after, that's letting you know you need to have a multiplier, meaning if there were 5 vertebral segments in this case, then you would account for the 1 with this first code, and then you would need ×4, or in this case it's ×2. So remember that with each additional, when you see that each, that means you got to account for each whatever segment interspace, it could be whatever. It could be a lesion, whatever. But that lets you know, because it's in the code language telling you you're gonna need to multiply something in order to get where you need to go. Okay, so here we're going to use the 63086 in conjunction with the 63085, and that we're indeed doing. All right, but we got to pay attention to now this. We've got the multipliers, but now here's this. We've got these blah, 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 modifiers. Okay, so what is this? We need to read. Okay, so we have two surgeons that are working together. All right, and each has a distinct part. We need a modifier 62, a 62. And most of you caught that. If you didn't, and it even tells you here the codes that you can use it with. And indeed, we do have 63085 there. Okay. All right. So we got to figure this out. There's an 82. What is that? That's for an assistant surgeon. All right. There's no assistant. This was another surgeon. This is a surgeon, another surgeon. There's no mention about anybody assisting the other. They each had their own procedure that they were doing. Okay, so 62. That's when you have two surgeons. All right, each surgeon has to report what they did. So each of them gets to put that 62 because one of them is accounting for the corpectomy. All right, and then the other is accounting for the vertebral decompression. All right, and so there we have the 62. It's what we need, and that's how we got to B. All right, so that's what tripped any of you up with D. You were close, but these modifiers. Okay, everybody was good with the multiplier, but the modifiers, you gotta have that. You got to have that down, like in your FTR. You can jot it down, just briefly, put it in there, at the bottom of the page if you want to. Just make yourself a note, okay? Just knowing that 62. So I think most of you grabbed that. If anybody wants that screenshot, okay, yeah, those modifiers, they are key. And I'm gonna be honest, when I first started code, that was like, I would go through every single thing, and the modifier would be that last little piece of the puzzle. And I go digging in the back. So you have a brief explanation in the front of your book. Don't forget where things are in this book. In the front cover on the inside, there's a brief explanation of the modifiers. But if you need just a little bit more, you can flip to the back of the book, okay, if you need a little bit more explanation. So do not be afraid of digging into this book. Your modifiers are they start on page 809 in the 2020 CPT manual, your appendix A. It'll give you further explanation if you need it with those modifiers, okay? All right, so I'm gonna stop right there. I'm big on those modifiers now, because look, there we go. Tip: check those modifiers to eliminate those wrong answers just a bit quicker. All right, yes, I know, Tamika, they used to freak me out too. Yes, you will get better. All right. Okay, here we go. We're gonna move on into another section. You guys are neuro pros, so let's get some things in with some eyes and some ears. All right, so I'm gonna have Miss Chimway come, and we're gonna head on into our next code series. Thank you, lady.
All right. A 69205, B 69220, C 69200, and D 69210. What CPT code is reported for removal of foreign body from the external auditory canal without general anesthesia?
All right, everybody, you guys crushed it. Crushed it. Yes, to quote Mrs. J, outstanding. Okay, again, these are the types of questions when you see them, and you will see some that are just straight to the point. Nobody's trying to fool you or trick you. Hey, you want to make good use of these. All right, don't leave nothing on the table. All right, you guys already have figured it out that C is the correct answer, code 6200. All right. I believe that most of you got there. Let me be sure. Yeah, yeah, all of you got there. Okay, so we're just quickly going through. The key was just being sure that we're coding for that foreign body and that we are in the right place in the canal. Okay, so we are, again, pay attention to where you are. In this case, we're at removal. Okay. And so, hey, I'm in the right neighborhood. Let's find the right house. Okay. All right. So that first one, we're removing something, but it has impacted cerumen. And no, and we are looking for a foreign body. Okay. So we're going to take that one off, and we quickly can do so. And you guys did that in your code search. All right. For code 69220 debridement. Nobody's talking about that. We are trying to remove something. Okay, we're not debriding something to remove some skin or something. We are just trying to get that foreign object out of there. Okay, so we do have external auditory canal. All right, removal, external auditory canal. Yeah, I like it. Okay, and 69205 with general anesthesia, no mention of that. All right, so we have the proper code in C, which you guys quickly arrived at the answer. And again, when you get them like this, quick and to the point, take advantage of it. Make up some of your time on the exam and make sure it is right. Don't leave these points on the table. All right. Okay, we're going to keep on going. All right, now we have a baby here. They're going to need to have a little something done with their ears. All right, we have A 69300 times 2. B 69300 with a 50 modifier. C 69310 with a 50 modifier. D 69120 with a 22 modifier. A 6-year-old female with prominent ears undergoes a bilateral autoplasty. The surgeon makes an incision just behind the ear in the natural fold where the ear is joined to the head, exposing the cartilage. Cartilage is trimmed and shaped, and the incision is closed. Temporary sutures are placed to secure the ear until healing is accomplished. The procedure is repeated on the other ear. What CPT code is reported? All right, coders, you've got 2.5 minutes, and your time, it starts now. All right, I see everybody in there. And I do believe we have most of you have gotten there. Yeah, I'm checking. And if some of you didn't get it the first time, you had time and then you caught it. Okay, so hey, again, you guys are outstanding. You are using your forensic vision. If you're like me, to have the forensic vision, you gotta have forensic glasses. So I got mine on my head this morning. Here we go. Most all of you have said B for 69300 with that 50 modifier. Yes, indeed. So we're going to take a peek real quick at how you all got there. All right. We have the prominent ears. All right. Obviously, both of them. This baby's going to need to have their ears pinned. A bilateral autoplasty. Okay. Surgeon's going to make that incision. That cartilage is trimmed and shaped, and the procedure repeated on the other end. So they're letting you know 2 times over both ears. Okay. Are undergoing this procedure. For 69110, this is our parent code here for excision, external ear, complete amputation. No, nobody's cutting the ear off or anything. Okay, we're not doing that. We are repairing it. So 69120. No. So again, pay attention to where you are in that book. Let's find some repairs. No doubt this is probably under the excision section without me looking and not having the clipping above it. It's most likely in the excision part of that chapter, but we need to be in the repair. So let's take a look at code 69310. It is for reconstruction of the external auditory canal or meatoplasty. And no, we are not doing a reconstruction of anything. All right, we are repairing something. So 69310, we're going to take that one away. What about that 69300? All righty, we're talking about autoplasty, protruding ear with or without size reduction. Man, we've got a lot of stuff in there, good stuff. Okay, we've got the autoplasty, boom, protruding ear. Another way of saying prominent ears, all right, with or without size reduction, okay? You know, their ear, they were trimmed, okay? We did have a size reduction because the cartilage was trimmed and shaped, okay? All right, and it was repeated on the other ear, and because it was, pay attention to those parenthetical guidelines. You can't sign off on that code until you read what it says that's specific for this code. If there are parenthetical guidelines, make sure you put your eyes down there and take a look. So in this case, yes, for the bilateral procedure, we're going to report 69300 with that 50 modifier. Okay, and so that's why that one's no good, and we move on to 50. And you guys caught that you're going to need that 50 modifier. You're not going to say ×2. All righty, so there you go. All right, so I think that you guys are on a roll. I can see you guys getting faster. I don't know if you guys realize it, but you guys are coding faster, okay? And granted, some chapters take a little bit longer than others, but hey, the more you do it and the more you get used to thumbing through your pages to find these codes, the better you will. Yes, the chunning, the better you will be. Okay, I'm gonna finish that thought. And yes, chunning, it is everything. You are so right, Andrea. Yes, Miss Cheryl. New tips and tricks to help you guys get there. And yes, Karina, those parenthetical guidelines, you gotta check it. Yes, and with each week, Miss Cheryl, yes, it is sinking in. Okay, and I want you also to realize that chunning is a continual process. I still will see something and jot something down in that book like, I didn't think about that. And then boom, I'm putting it there. Or you might look up the meaning of something. Just make yourself a little note on the side if it's helpful to you. Chunning is a general guideline, but it's very personal as far as what speaks to you. Okay, so definitely you want to be aware of that, because for me, I highlight some things but very little. I tend to box things. The way I chun is typically the way I teach you guys in class. I like things very concise. I like to be able to see, and so the highlighting for me, I try to limit it so that when I see it, it definitely draws my eye. Okay, all right, so here we go. I'm gonna have my dear friend, Miss Chinwei, come and read to you coders. Thank you.
Okay, A 69799, B 69667, C 69714, and D 69710. A patient with severe mixed hearing loss from chronic otitis media undergoes a round window implant with floating mass transducer. What CPT code is reported for this procedure? Thank you.
Oh man. Hey, you guys didn't need all that time. I'm like, I'm gonna give it to them anyway, just so I have time to just say, hey, good job. I see what you're doing. I see what you're doing. I see some good answers. I got my last folks coming in here because I want to give everybody a chance to say, boom, it is A And you guys arrived at that answer. I'm loving it. All right. So we've got that severe chronic otitis media. They're undergoing that round window implant with floating mass transducer. Okay. So yeah, you guys were like, boom, hey, come on, give me my props, and I'm gonna give them to you. I was in the chat too. I was like, look here, let me get in here with Miss Chinwei and see what these coders are doing. I'm loving it. All right, so we're gonna start with code 69667. It is a repair, but it is of the round window fistula. Okay, so we are talking about an implant. All right, so already gotta go. All right, so we're quickly moving through these things. This is an implant or replacement of the electromagnetic bone conduction hearing device or temporal bone. All right, no mention of an implant or replacement. This is being implanted. Okay, so it doesn't mention that they're replacing anything. So if the doctor didn't say it, it did not happen. All right, so that code 69710, that is gone. All right, so also the other thing, they're talking about the temporal bone in this case. Okay, so we are dealing with chronic otitis media. Okay, so nothing, no mention about the temporal bone either. It's just telling us chronic otitis media, and they're talking about the round window. All right, so no mention of that particular bone either. So we just already know wrong procedure, not implant or replacement. No mention of that. Okay, so for this one, we're talking about an implantation of an osseointegrated implant. Okay, but we are talking about a round window implant. So we're just going to keep it simple. Again, just matching up these key words. Okay, so again, we're not seeing that. All right, now this unlisted 69799, and it's down here all sneaky too. Okay, just like the unlisted procedures, they come at the end because they're like after you've exhausted everything and you just don't see it. The last resort is to go down here. We don't see anything specific for the round window implant with a floating mass transducer. We do know it's of the middle ear because it's chronic otitis media. Okay, so otitis media is inflammation of the middle ear. Okay, and so it is an unlisted procedure. And when I tell you, I threw this one in here, you might see something like that, you might not. But just like modifiers took me a minute to wrap my brain around, unlisted procedures did too. Because I would keep going round and round to try to make that thing fit. I was going to make it fit. Okay. So, yeah. Yep. It wasn't. That's right. That's right. First time for that unlisted. Okay. All right. So, you do try to see stuff. It's like I'm gonna read it in there. It's gotta be there, all right? But in this case, it wasn't. And you guys definitely have a firm grasp of these keywords because it didn't sway you to try to make it fit. I was almost thinking that you guys were going to waver between these two here, particularly the 69714. I thought, okay, they're gonna go with it because it's implant and that, and they're gonna say maybe this right here has something to do with that. I don't know, but hey, that's right. If you don't see it, don't force it. Okay, if it's a circle and and it's a square hole, don't try to push that thing in there. You like trimming some stuff off, and hey, I get it. All right, so you guys did fantastic with that one. All right. So I'm going to have Miss Chinwei come and we're going to start going over eye and ocular adnexa. All right. So here we go, guys, ladies. All righty. Oh, you know what? Real quick though, make sure in your book, and I'm sure most of you do, that you have your 6 muscles of the eye. Okay, you've got 6 of them. You've got 4 vertical and you've got 2 horizontal, and the main thing you want to do is to notate on on your um on your picture in your book of the eye. Notate where these muscles as far as horizontal and the 4 vertical. Okay, because that will help to drive you to the proper code when you're coding anything related to eye surgery and all that stuff. Okay, so I'm sure you guys have already chunned it, but if you still have a little work to do, make sure you pop these things in here, okay? Because some stuff you just gotta have. All right. Okay. Now I'm gonna advance the screen to the next scenario, and here's Miss Chinwei. Thank you so much, lady.
All right. A 67901, B 67903, C 67906, and D 67908. The patient was taken to the operating room. The provider everts the upper eyelid and places clamps across the everted undersurface of the upper lid. The tissue distal to the clamps is excised or resected. This tissue includes conjunctiva, tarsus, Mueller's muscle, and the distal insertion of the levator aponeurosis. The remaining tissue is reattached and sutured. What CPT code is reported? Thank you.
All right, guys. I see ya. Like I told you guys in the chat, go ahead, take a bow. Just drop the mic. Just drop the mic and walk on off the stage. Say, I can't do no more. I can't do no more. I'm leaving it all on the stage. You guys are doing just outstanding. This was one of my favorite sections when I got along into nervous pretty good, but I liked nervous eye and ear. And so I definitely made it one of my like if you've gone to boot camp, they will help you with a testing plan. And so this was one of my master sevens as well. Okay, but definitely make sure you're proficient all the way around. I will give you that advice. Have your master seven, and for those remaining chapters, just be proficient. Okay, but definitely you bank on it. Okay, because I banked on those seven. And then those the other seven, the 50 questions that are kind of like real quick. You have your master seven, and then you are going to have your, gosh, I forget, it escapes me, but it's like your med term and that kind of stuff. It's about 50 questions, so you definitely want to grab those two. Leave nothing on the table. Yeah, y'all are Renita. Yes, y'all are doing the doggone thing. Yes, y'all are. So here we go. All righty, so we've got D. All right, so we're going to take a look at these keywords. This patient is going to that operating room. Provider is going to evert the undersurface of the upper eyelid, and they're going to excise or resect the tissue that's distal to those clamps. And the tissue that's included in the dissection is the conjunctiva, the tarsus, the Mueller's muscle, and the levator aponeurosis. Okay, so let's see what we've got. We've got for 67901 repair of blepharitosis. Blepharitosis. Okay, so blepharitosis is drooping of the eyelids. All right, so that skin is kind of sagging, and I can imagine that would be a bit tricky for a person because sometimes the eyelid can droop to the point that it impedes the vision of the patient. So in this case, they're talking about a frontalis muscle technique. There's no mention of a frontalis muscle technique. We do know that they are repairing the eyelids, but no mention of frontalis muscle technique to do so. So we're going to take the 67901 off. Okay, but we're in this good code family. Okay, so don't forget, which you guys obviously are not. These are one of the ways that I will oftentimes do my book is to box in the common code language so that I wouldn't get thrown by thinking maybe this code is wrong when indeed the code could be proper, because the code language is common to this whole family is on point. And so the dependent code is what would complete it for me. So we're going to continue on. Although that parent is wrong, this common language is good. The parent is wrong because of the code language specific to it. And you guys picked up on it. I love it. All right. So for this one, we have the torso-levator resection or advancement internal approach. Okay. No mention of an internal approach. We know that the upper eyelid was everted. Okay, so no mention of that. So we're going to take that off. Again, matching up the keywords. If you're like me, there were times I could kind of start floating off into left field, wanting to know what everything meant and what it was. You match up those key terms, okay? If something just really, really strikes your fancy, you can jot it down and look it up, but I don't want you to get caught out there, okay? Because the main thing is you are tasked with understanding and knowing your coding guidelines and being able to look up your code language and find what that provider has spoken to you via paper, because if he or she didn't write it down, it didn't happen. So you're working within the confines of what they give you. All right, so for 67906, we're talking about a superior rectus technique with a fascial sling, and it's including obtaining the fascia. There's no mention of that. So we're taking that one off as well. But again, getting back to those keywords, conjunctivo Mueller's muscle levator resection, e.g. Fascinella savant type. What's this thing? Okay, so here's an example of when I was saying you might want to jot some things down, and it depends on you. Okay, so the Mueller's muscle conjunctival resection, or MMCR, it's a blepharitis repair, blepharitosis repair. And so sometimes these are just little things that I would write down off to the side or kind of like this in my book, because then when I'm reading it, then I would understand, okay, if they start mentioning this, okay, they're talking about an eyelid, or they might say drooping eyelid. And I'm like, okay, so let me start reading. Now if they're talking about drooping eyelid, boom, they could be talking about this. All right. So it helps to point you. So here we go. What was excised? The conjunctiva. Okay. The tarsus, the Mueller's muscle. All that right there. Conjunctiva, tarsus, Mueller's muscle. There we go. Levator aponeurosis. Okay. All of that stuff. That's it. That's a lot of keywords that we grabbed with that one code. So 67908, that's it. And you guys already got there. I just wanted to share with you some ways that you can kind of notate, because for some people you just kind of want to know. And so for me, sometimes I would want to know, but don't start selling off into left field. Just every now and again you can jot some things down if you feel like it would give you more clarity. Okay, but this exam is designed to test your ability to follow your guidelines, use your keyword concepts and things. Okay, all right, so here we go. We're gonna go ahead and do another one. I'm gonna call Miss Ching. Come on, lady, let's do another for these folks.
All right. Okay. A, 6722950. B, 67229 times 5. C, 67229 69990. And D, 67229. An infant born at 33 weeks underwent 5 photocoagulation treatments to both eyes due to retinopathy of prematurity at 6 months of age. The physician used an operating microscope during these procedures. These treatments occurred once per day for a defined treatment period of 5 days. How would you report all of these services?
All right, you guys know what time it is, and I know if you're like me, sometimes you're like, "Oh man, hold on, hold on, hold on! Don't tell me yet! Don't tell me yet!" Hey, I'm gonna give everybody, if you need it, just a few more seconds. I'm gonna give you just a few more seconds to go and pop that answer in there. But other than that, I'm gonna start explaining this one so we can continue to try to squeeze one more in, okay? All right, you guys are doing fantastic. And for those of you who just missed it, just a peek, just a little bit, okay? That's okay. We're gonna get you there, okay? Because this one right here, I know it can drive you nuts. All right. So this time I get a chance to move that out the way without exposing the answer. Okay. So we're going to start with underwent 5 photocoagulation treatments to both eyes due to retinopathy of prematurity. And then we have the operating microscope once per day for a defined treatment period of 5 days. All right. So all of that is good stuff. And it's going to lead us to A. All right. All right. Let's see how we got there. So for this one, we are only dealing with this code. And then this right here, we know we're talking about microscope. All right. So we have one or more, we have treatment of extensive or progressive retinopathy, one or more sessions. Okay. Preterm infant, less than 37 weeks. So yeah, we already know that that's the right code because that's all they gave us. So you're probably trying to figure out, well, why is that all they gave us? But look at all these ways you could spin this code, and only one of them applies to this scenario. So again, noticing where we are, we're talking about destruction. So for this particular code series, these codes should be reported only once during a defined treatment period, okay? And so it is including the code 67229, all right? We only can use that thing one time in this treatment period, okay? So, all right, so we've got this 67229. It should be reported only once, all right? So we're gonna see what we got going here. Take that off, there we go. All right, so the treatment occurred once per day for a defined treatment period of 5 days. Okay, so we've got the defined time. All right, and so we're going to take that away. We don't say times 5. Okay, because it tells us it should only be reported once. All right, so we know it should just be reported once. We don't have to multiply by 5 to account for the days. The code language is telling us that it it should only be reported once, and they've given us the defined treatment period. It's 5 days. Okay, they could have said the defined treatment period was 10 days. It would only be reported once. As long as they say what that treatment time is, doesn't matter. We're only going to put it down one time. Okay, so we don't do times 5 to account for the days. Like I told you, this 69990, yeah, that is the microscope, okay? But we do not report this, okay, in addition to these particular procedures, okay? And right there, we see that 67229, it falls within this category. Okay, so make sure on your page with the 69990, this is what you would want to box in or highlight, or however you bring your eye to certain things in some code language or some instruction. Then you want to bring your eye to this to know that anything falling in here, you would not report this along with 69990. Okay, so we're going to take that one away. Now we got 50-50 shot at this thing now, y'all. We got a 50-50 shot. Okay, so here we go. We got the 67229, and yeah, we have got to take a look at these parenthetical guidelines because now these things are specific to this code. All right, so for a bilateral procedure, is it bilateral? Yeah, they said both eyes. We're going to use that modifier 50 along with that code. So we're going to take that one away because we need that 50 at the end of that code. So 67229 with a 50 modifier. I know, man. I
Thank
used
you
to
for watching
shudder
an
to think
AMCI
about it.
exclusive
Oh, that's
presentation.
a modifier. Yes, we need it in this case, okay? So this was an exercise in making sure you can maneuver it, understand these guidelines, okay? Yes. All right. So yes, it would just be reported just that one time for that treatment period. Yep. Yep. Just one time for the treatment period. Okay. All right. So, how we feeling, guys? How we feeling? Argentina, did that answer your question? All right. All right. So everybody's cool with this. So anything related to that 67229, I want to see y'all just bam. Like I got what? Give me something else. Because that's all you got. I know this. I know this and I got this. All right. So I'm pretty sure we have time for one more, Okay, so I'm gonna go ahead and read us out with this one, and I know you guys are probably already working on it. Okay, because that's what I used to do in group study too. I'm like writing and figuring out my game plan, my approach while it's being read. So hey, and I'm buying your time by chatting. Let me go ahead and read this thing so we can solve. So we have A 67916 with a 50 modifier. B 67916 with E4 modifier, 67914 with E2 modifier, C 67914 with the 50 modifier, D 67923 with an E4 modifier, and 67921 with an E2 modifier. A 65-year-old patient presented with ectropion of the right lower eyelid. Repair with tarsal wedge excision is performed for correction. Attention was then directed to the left eye. The patient also had an ectropion of the left lower lid, which was repaired by suture repair. All right, coders, code this procedure. You've got 2.5 minutes. I know you got this. Your time, it begins now. Oh, yeah. Okay. I wanted to give you guys time. I had a few more people to get that answer in there. I didn't want to do the reveal just yet. Don't you just hate when, like, you sit down and sometimes I'll come in late into the den and then my husband will spill the beans. Oh, yeah. I'm like, no, no, no. Don't tell me what happened, man. Let me find out for myself. All right. So here we go. We are going to take a look at this and we're going to unpack it before we get out of here. And you guys, get on your way for your Saturday because I do appreciate you guys spending the first part of it with me. So here we go. All righty. We have this 65-year-old. They presented with an extropion of the lower right eyelid, okay? And then they're going to have a repair with a tarsal wedge excision. And then attention was turned to that left eye, which also had an extropion of the lower lid, okay? And it was repaired by suture. All right, your answer is B. And we're going to take a look at why. And like I was telling many of you, yes, I can see that CPC certification in your future. Now you got to see it, okay? Because I see it. I feel it in my bones. You got to feel that thing, okay? It's got to resonate with you. So here we go. We're going to head on down. We're going to take a look at these HCPC modifiers because these get even more specific when it comes to the eyes. You don't just have just a 50 modifier or even just a bilateral in the code language. It gets deep, okay? It starts going with E2, E4, okay? So use that to your advantage, all right? So that's why I'm bringing that to your attention. Go ahead and get that out of there, okay? So knowing that, because when you look here, there is no 50 for bilateral, and I could see how this could trip you up if you didn't realize that there were modifiers that are more specific. Yeah, that 50 means bilateral, but in this case, we can be more specific. Again, we want to code to provide a certainty and specificity, and we can go better than bilateral. We can say left eye, right eye. Okay, so let's go ahead and take a look at what we have left. We have 67921. Okay, and that's the parent. And we already said if that parent is wrong, this is repair of an entropion, and we are dealing with ectropion. Okay, with an ectropion, and so it doesn't matter whether or not that's correct. This is wrong, so that's wrong, okay? So we're going to take code 67923. We're going to take that out of there. So all we're doing now is just verifying, okay? We're just verifying. All right, we already know repair of ectropion. Yeah, that's what we talked about, ectropion. All right, we're talking about a suture repair. All right, so we have 67914. All right, but we also had that tarsal wedge excision as well. Okay, excision of the tarsal wedge for that 67916. Okay, and then for that first one, 67916, there we go, excision of the tarsal wedge, and then repair of the ectropion, the suture, 67917. So you're gonna sequence this one. I know it's a dependent, but this is a more involved because now you're talking about excising. So you would agree that excising something around the eye to repair it would be more extensive, more complex than just simply suturing it. Okay, so yes, that's right, you got it, Miss Cheryl. So that's why this 67916, that's going to come first. We have an excision, tarsal wedge, and then we're going to follow it with the ectropion of the suture repair. Okay, again, notating where we're talking about for the 67916, which I got the tarsal wedge. You guys already figured it out. It's that right lower eyelid. And that right lower eyelid, it needed that E4. And the left one needed the E2. So, hey, they're spot on with it. And indeed, B is the answer. Yeah, yes, be careful with that ectropion and etropion, okay? If you have to, what I will do sometimes when things are so close like that, so that I don't, because you're going to be going fast. You're going to be going fast, and your nerves will sometimes kind of rise up a little bit, but you got to get that down. I would sometimes on the side here in like red, in caps, I would say EN, and then in blue tropion. So to draw my eye to N, and then for ek, come down here with red in caps, right? EC, and then the remaining portion, tropion, put that in blue. Okay, so I would do little tricks like that depending on if I were in certain sections and I felt like, let me be sure I don't get, tripped up. Don't get caught out there. Okay, so that is all I have for you guys. Miss Chinway, you want to come on and tell these coders good day and all that stuff, because I'm gonna let you guys go. Hey, we right on it.
Yeah, it was really a nice experience having you all on board and seeing the excitement and everything. And I hope you really had a great study time. Wish you a wonderful weekend and beautiful day tomorrow. Thank you.
Thank you, Miss Chinway. Thank you so much, coders, for hanging out with us today. You guys are just so appreciated. I mean, hanging out with us for this moment. I hope that we have made good use of your time this Saturday morning. I do not take it for granted that you have shared 2 hours of your precious time with us today. I hope we've made it well worth your time. That is our goal. And hey, come on back on next Saturday and hang out with us again. We would love to have you. All right. So if there are no more questions, I don't think I see any, then hey, we're gonna let you guys go. Please remember to send us your feedback, guys. Fill out any kind of feedback information you'd like for us to have. Let us know what worked for you, what you'd like to see more. We appreciate you, and we will see you on next Saturday. Have a great one, guys.
Thank you for watching an AMCI exclusive presentation in partnership with AAPC. Until next time.